out here on such a cold day. I just want to let you know, if you're following our seminar series, the last person on the list, Dr. Nigel Gopi, is actually not going to be here. He got a job in the States and he's on his way within the next couple of weeks, so he couldn't make the seminar, but just so that you're aware of that. But no worries. And I just wanted to say that we're very pleased today to have with us Dr. Mary Fox. Dr. Fox is a graduate of U of T. She did her doctorate here in the Faculty of Nursing. And she also had a CIHR fellowship, which is quite amazing, I think, for a doctoral student to have that kind of support for their studies. And she's actually doing a Career Science Award from the Ministry of Health and Long-Term Care here in Ontario. So she's carrying on her research legacy or saga at the University, or at York University rather. So we're very pleased to have her with us here today. Thank you for coming, Mary, and we're looking forward to your talk.
Thank you very much. And it's my pleasure to be here today. I'm curious to know where you're all from. Are you students here? In your life course? You're not a student? Where are you from?
I recently finished a Master's in Social Work at York.
Oh, okay.
I'm looking to work with seniors and older people, so this is great kind of continuing education for me.
Okay. Well,
and I'm a clinical speech pathologist who teaches in
okay.
faculty of medicine.
Okay, you teach over there, do you?
I do.
Okay. Any other career people or professional people who are speech language pathologists or in physio or nursing? No? Okay, well, welcome. I'm really pleased to be here today. What I'm going to talk about today, and please interrupt me as I go along if you have any questions, really evolved out of a pilot study that I did for my PhD here. And in the pilot study, I thought I was never going to finish my PhD because in the pilot study, the participants expressed a lot of difficulty understanding the questionnaires that I was using in my PhD. And so part of that research was a qualitative study in which I asked them to tell me their interpretation of the questions after I administered the scales and asked them to give me their responses. Then I did detailed interviews about their interpretation of the questions, the items, and the responses. And I have to thank those participants and acknowledge their input into this idea for this study, because several of them said, you've got to break these questions up. So that's what this study is about. And so I'm going to talk a little bit first about symptoms and standardized self-report scales. Most of my work is in the area of fatigue, insomnia, and orthostatic intolerance. And those symptoms represent a cluster of symptoms that can prevent participation, a person's ability to participate in physical activity because of the way they feel. And for people who are hospitalized, either in rehab settings, long-term care, complex continuing care, or even in the people who are in the community, this can kind of prevent their ability to participate in physical activity, and it can prolong their recovery. So any kind of research I would be doing that might be an intervention type study would involve using standardized scales in order to assess the intensity of the symptom, to see if there's any improvement in relation to the intervention. So symptoms they're really personally experienced, right? So they're best assessed using standardized self-report scales. And these kind of scales have many advantages. They're very efficient to use. Most of them take about a minute or two to fill out. And what they do is they generate comparable data, which we can use to either guide clinical decision making or compare before and after an intervention or between groups to see if there's any improvement in the symptom. And however, that kind of use is really based on the premise that the person understands and responds to the scales as was intended by the person who developed the scale. And when I did my pilot study, I found several very established standardized scales measuring these symptoms were very complex and difficult to understand and burdensome for the older participants. And so what's the difficulty with scale misinterpretation and response burden is that they can really contribute to measurement error, and which can kind of render our data comparisons and practice decisions invalid. Because we're trusting that those data are valid and reliable. So I'm going to go over a little bit about the ability to answer a question, fill out a survey, and what that's influenced by. So it's influenced by three things. One is characteristics of the person who's answering the questions. And I need to first of all say that responding to standardized scales actually requires quite a bit of mental effort. We all know when we filled them out, we get to the end, we're kind of getting tired of filling them out. And that's because we need to think about what the questions are asking us, right? And kind of go in our head, what was our experience with what they're asking us, and how do I really feel about that, or how did I experience in the last 2 weeks, or whatever the time referent is. And in people, particularly people who are either hospitalized or experiencing an illness, they may not have tons of cognitive energy to respond. So they might get a little bit more tired as opposed to somebody who isn't experiencing some kind of illness episode. And in older adults in particular, this might be compromised because normal aging is associated with declines in working memory and attention. The second characteristic is the environment. Any kind of healthcare setting is known to be, if anybody's been in any kind of healthcare setting, you know they're very distracting, right? There's constant things going on within the environment, and most kinds of clinical research is really done at the bedside or in a rehab setting where there are other things potentially going on. And distraction while encoding an experience can decrease a person's ability to recall it. And so when we're asking somebody about a symptom, we tend to ask, sometimes the scales ask for in the past 2 weeks or the last 2 days or the last week. The person has to be able to recall their experience with it. And older adults are more vulnerable to the effects of distraction. And in the last thing I'm going to talk about here now, and that's going to be the main focus of the presentation today, is scale construction. Items, or a question that is too long, if we have greater amount of item text, there are studies that have looked at this, quantitative studies that show that the longer an item is, the less valid it is. And also, asking multiple questions within a question can be particularly difficult for people, and potentially inapplicable content. You all know when you've been asked to answer to something and it's like, well, I don't experience that. Why are you asking me about the intensity of that experience? So this will be the focus of the presentation today, is scale construction, because we can do something about that actually, right? So what are complex items? Complex items contain large amounts of information. When we have a symptom question, we usually have the name of the symptom, could be dizziness, it could be tiredness, and we have the intensity of the symptom in that question, or the frequency, and we also have a time reference. So there's a lot of things already with symptom type questions. And complex items target multiple pieces of information. And they have been identified in the literature as a major reason why older adults might experience difficulty responding to them. They can be difficult to answer and burdensome because they're a little bit more taxing cognitively. They require a little bit more energy to answer. Okay, so I'm going to give you some examples. I'm going to start off with this one. Take a minute to read it. And what do you tell me what that item's asking you? It can be anything.
So on the fatigue scale, it's asking me, in the last 2 days, have I been, and it's confusing because is it one time, is it at any time in the last 2 days, or is it consistently over the last 2 days, or just when I woke up in the morning or whatever? It's saying at any point over the last 2 days, have I felt tired?
Have I felt tired? And what else is it asking?
And did other people
No,
notice?
okay, because you started talking about the fatigue scale. So we'll go with that one.
Did I
which is
feel
fine.
tired, and how much?
Did I feel tired and how much? Okay, so it's really asking two things. First, the person has to think about, did I feel tired in the past 2 days? Okay, yes, no. Then they have to think about, to what degree did I feel tired? Okay, that's a relatively low level of complexity. It's asking me to think about two things. It's kind of like two questions within a question. So how about the next one? And I'm going to read it for those people who may not see it on the camera. So the next question is asking, how noticeable to others do you think your sleep problem is in terms of impairing the quality of your life? The reason why I didn't want to read it at first is because every time when I read this, people say, of course, that's a complex item. But you don't really notice how complex it is when you're reading it for some reason. So tell me what do you think that question is asking you? What do you need to think about in order to answer it?
What part of your sleeping is a problem? You also have to consider how much it impairs the quality of your life, whether or not it impairs the quality of your life, and then you have to also consider how noticeable it is to others, whether or not they can notice your sleeping problems.
Yeah. So that's quite a few things. So this question is really asking, first of all, do I have a sleep problem? Okay. Do other people, does it impair my quality of life? Do other people notice this? Then, how much do they notice it? So that's really asking 4 things within a question, okay? And this was one item in the qualitative study that people, it was one amongst many that the respondents said, you know, I don't know what you're asking me. And this was one they were recommending, you have to break it up. It's asking me too many things. Okay. The next thing about scale construction is potentially irrelevant content. Okay, and that's content that expects respondents are experiencing the subject of the item to varying degrees. Okay, so many symptom scales expect that the person answering it is experiencing the symptoms. So if we look at orthostatic intolerance, and what that really is when you get up, you've all experienced when you stay too long in bed sometimes after a long night out, and you get up and you feel like a little bit dizzy. Has anybody experienced that? Yeah. Or you've been sick and you're in bed too long, and then you get up and you feel that way. So those kind of scales will ask about things about dizziness, about lightheadedness, about nausea, about perspiration. So they're asking a lot of different items to try to get at the full experience of the symptom. And so it may not every item there may be applicable to every person who's responding, and this could lead to response burden and missing data. Okay, and I give you an example of this using the Insomnia Severity Index, and these are a set of items out of the Insomnia Severity Index. So the first group of questions asks the person to please rate the current, i.e. last 2 weeks, severity of your insomnia problems. So difficulty falling asleep, so you can answer none, mild, moderate, severe, very severe. Difficulty staying asleep, the same thing, and problems waking up too early. Then there's a next set of questions, and the next one asks, how noticeable to others, that's the question we just went over, do you think your sleep problem is in terms of impairing the quality of your life? How worried or distressed are you about your current sleep problem? And then to what extent do you consider your sleep problem to interfere with your daily functioning, example, daytime fatigue, ability to function at work, daily chores, concentration, memory, mood, etc. Okay. So, and I'll give you a little example from the prior qualitative research is people said to me when I got to the second question, and then I read the next one and the next one, they said, I already, and they emphasized already, told you that I don't have a sleep problem. And then some people, what they did, after I asked this one, then they started saying, no, no, even before I had asked the question. You have to remember, like in the context of somebody who is hospitalized, who may not be well, is experiencing an illness episode, they tend to be tired already. So this can actually cause more burden to respond and be a bit more tiring. Okay. So what is the response tree format? You probably have a little bit of an idea because we broke up a couple of items. A response tree format is also referred to in the literature as a filter question, contingency, and screener questions. It's a really easily implemented strategy, and what it involves is breaking up those complex items that are targeting more than one piece of information into separate items, and then only asking about the dimensions of the subject of the item if the person answers yes. Oops. Okay. And in the literature, there's a lot in literature about older adults that recommends using the response tree format because the response tree format has been proposed to decrease the amount of information the person has to process, right? It decreases the asking irrelevant questions. It reduces the complexity of the cognitive tasks involved in responding. The questions become shorter, more specific, and the person has less information to attend and process at one time. Okay? And in prior qualitative research, the response tree format has been found to improve comprehension, facilitate responding, and to decrease burden in older people. Okay. However, okay, in the research, in the literature, there's many cautions about using the response tree format, and most of this is in public opinion research. And the research says that it can lead to, well, first of all, it says that people very quickly will pick up that answering yes leads to more questions being asked, okay? And we all want to get out of work, don't we? So they may begin to start to underreport because they know that if they say no, they quickly learn that you're gonna leave them alone. Okay, so there's that concern. There's also the concern that because the person doesn't get asked the intensity of the symptom if they answered no, it may convey that the person asking the question is only interested in severe cases or symptoms. So there's also a concern too that it could lead to more social desirability, and this could be seen with increased reporting of the symptom. It could also, some researchers have proposed, it's going to be more time efficient, because you're not going to have to ask all those questions of everybody. If we put in a filter and we stop them when they say no, we don't have to ask all the next questions. But there's other people who say it's going to take longer to answer questions with a response tree format, because you're breaking up all these questions, it's longer, and it will take longer to respond. But there's really hardly anybody's done any studies about this. Very limited empirical evidence. So on one hand, we've got, we know people who are older, and people particularly who are hospitalized will have more difficulty responding. We've got the literature recommending how to facilitate their ability to respond by using a response tree. And then we have other researchers who are saying don't do it, because you're going to end up with very questionable data that you won't be able to trust, that isn't valid, that isn't reliable, and it's not going to be useful to you. It's going to take longer for you to do. So what to do? You do a research study. Well, we're going to test it, right? And so in this study, what we did, we asked, what effect does the response tree format have on the psychometric properties and utility of 3 scales measuring symptoms? For utility, we looked at time to complete the scales. So does it take longer? Does it take less time? We looked at, are there more missing responses? Okay. And what is the level of difficulty responding to the scales in both of the formats? And we also wanted to know, because the literature talks about aging and the changes with aging, are there any age group differences in the utility of the original and the response tree formats of these scales in a cognitively intact group of younger and older inpatients? Okay. So in order to do that study, we used a comparative cross-sectional design. And the comparative aspect involved 2 age groups, younger age group, which 30 to 50 years old, and an older age group, 65 plus. And it also involved 2 formats of the 3 scales. So the one format was the original format, we didn't touch that, and the second format was the response tree format that we revised. And we also randomized the sequence of the scales and of the formats. And both age groups received both formats in a counterbalanced order in order to control for an order effect. And they received a 15 to 30 minute break, rest period halfway, where the research assistant left and said, okay, I'm going to stop asking you questions, you'll have a 15 to 30 minute break, and then I'll come and ask you the next set. And that was to control for potential response burden in the older participants. So what do we exactly do when I said we revised the scales? And I'm going to give you an example with the items that we talked about earlier. So that earlier item was item number 3 from the Insomnia Severity Index. And it asked, how noticeable to others do you think your sleep problem is in terms of impairing the quality of your life? And so what we did for that one is we broke it into 3 dichotomous and 1 ordinal item. And we tried every effort to maintain the content and the response option content as well. Okay, so the first one is, do you have a sleep problem? Yes or no? Does your sleep problem impair your quality of life? Yes or no? Do you think other people notice that your sleep problem impairs your quality of life? Yes or no? And if they answered yes to all of the preceding sub-questions, then they were asked to respond to how noticeable do you think this is to others, with the same potential response options. If they answered no, way up here to the very first one, they weren't asked these next questions, nor were they asked the 4th or the 5th questions contained within the scale. And the 4th question is, How worried, distressed are you about your current sleep problem, and to what extent do you consider your sleep problem to interfere with your daily functioning? So that gives you a little bit of an idea of what we did. Okay, so we wanted to test that. And we tested it in an urban inpatient rehab facility. And the sample included people who were 30 to 50 years old or 65 plus, who were able to read and speak English, and they were all undergoing inpatient rehab. And people were excluded if they had any diagnosis known to adversely affect cognition, and you can see them all up there: Alzheimer's and related dementias, MS, cerebral palsy, and there's a number of them down there. Okay. So what did we do? We administered both of those formats of 3 scales measuring the symptoms: fatigue scale, the orthostatic intolerance scale, and the insomnia severity index, in a face-to-face interview with each participant. The participants were all given a copy of the scales, and which were administered by a research assistant, who said to the participants, read along the questions, and I'm going to read out loud the questions and the response options. And then the research assistant circled the response options for all the participants. We needed to maintain it the same for each group. Okay. We also, for utility, we developed a questionnaire, self-reported difficulty responding. So we asked participants if any, at the end of each scale, and each format, so they were asked 6 times, were any of the items in this questionnaire at all hard or difficult to answer? So if they answered yes, we did a little response tree format in this one too. They were then asked to indicate the level of difficulty. We also looked at number of missing responses, so questions that were left blank, or to which the participant said, I don't know, I don't have an answer. And we timed how long it took them to answer each scale using a stopwatch. We also collected demographic and health data, and we administered the mini-mental scale at the end of the interview. The research assistant administered that. So for our data analysis, in order to find out if the response tree format had any effect on the psychometric properties, we did a Cronbach's alpha for internal consistency reliability. We did confirmatory and exploratory factor analysis for factorial validity. And we did interclass correlation coefficients to find out what was the degree of the level of agreement between the 2 different scale formats. And we, in order to look at construct validity, we did a Pearson's correlation coefficient between scales. We determined were conceptually related. So what's the degree of correlation between the insomnia severity index and the fatigue scale, and the orthostatic intolerance and fatigue scales. And in order to determine the effect of the response tree format on the scale's utility and age group differences, we used a mixed design ANOVA with age as a between group factor and format as a within group factor. And where any of the violations, assumptions were violated, or there was really too little variation in the data to conduct any of these analyses, I'm going to report descriptive statistics. Okay. So our results. We had 86 rehab inpatients, and 43 were from the younger group. Their mean age was 39.6 years. And we had 43 participants from the older age group with a mean age of 78.5 years. And in terms of gender distribution, a little bit higher were women, 55%, and the average length of stay, the median length of stay was 15 days. And most of the participants were admitted for rehab secondary to a traumatic bone fracture, spinal cord injury, or a surgical thing like a hip fracture surgery, hip repair. The average mini-mental score was 28.6. That's very high by way of the exclusion criteria. And the highest level of education for the group was high school or technical training. Okay. So the effect of the response tree, the results on the scale psychometric properties. All of the Cronbach alphas for both formats, all the scales, were greater than 0.70. There was a high level of agreement between the two formats. Interclass correlation coefficients were greater than 0.70, which indicates a very high level of agreement. In terms of concurrent validity, there were strong correlations between conceptually related scales. So those range between 0.59 to 0.68. And in terms of factorial validity, we first conducted a confirmatory factor analysis, and we couldn't confirm, the results could not confirm the expected factor structure in either format for any of the scales. So then we proceeded, as recommended in the literature, to an exploratory factor analysis, and there were no differences between either formats. Both formats explained a comparable percentage of the variation, and there were no cross loadings. The loadings were fairly comparable. In terms of the effect of the response tree format and age on missing data, there was very little effect actually, and fewer than 5% of the responses to any item in the two formats of the three scales were missing for the total sample. And this was not consistently related to any specific scale, format, item, or participant. There was a slight age group trend. The older age group had more missing responses to the original formats of the orthostatic intolerance scale and the Insomnia Severity Index than in the response tree formats. Whereas the younger age group had the opposite. They had more missing data in the response tree formats, so 7% and 9.3% to the orthostatic intolerance scale and the Insomnia Severity Index compared to the original formats, which were 0 and 4.7%. Okay. We couldn't test that though because it was so little variation. In terms of the effect on self-reported level of difficulty responding, there was also little effect. The median score on that item was 0 for all of the scales in both formats, meaning the average participant did not find it at all hard or difficult to answer any of the questions in the scales. Not one person in the younger age group found it at all hard or difficult to answer anything. And only 3, which represent 7% of the older participants, said they found any of the items difficult to answer. Okay. So now we're going to look at time. So here's for the 3 scales and the different formats, and the mean time in minutes for the total sample. So you can see by looking at this, for the total sample, the response tree format actually took slightly longer to respond to than did the original format. Okay. And here we see a bigger difference in the orthostatic intolerance scale. When we look at it by age, we see that for the younger group, this holds true for the younger group, with the response tree consistently taking longer to answer than the original formats. But when we look at the older age group, I'm going to start down here with the Insomnia Severity Index, it's almost exactly the same. Slight difference by 2 seconds, which is really almost nothing. So the response tree format for the ISI took a little less than the original format. For the fatigue scale, exactly the same. And for the orthostatic intolerance scale, the response tree format took longer. What I'm going to explain some of these results right now is that I explained to you what we did for the Insomnia Severity Index, how we broke it up. Same, you can imagine what we did for the fatigue scale. So you saw one of those items. Now, the orthostatic intolerance scale, the original format provides instructions right at the top. It tells the respondent that we're going to list symptoms, just circle the intensity. So it doesn't have an actual question with each symptom. So it just lists nausea, dizziness. It has one word with the scale at the top, and then they can circle not at all, mild, moderate, severe. What we did in the response tree format is we put instructions with each item. So we repeated, in the last 2 days, did you experience any nausea? Yes, no. And to what degree did you experience? So you can see why it took longer for that scale. And we had to do that because we didn't just want to list the items. There was no way to break it up, but it actually may have confounded the true effect of the response tree. Okay. In terms of the ANOVA, so that was statistically significant difference. The difference was significant for the orthostatic intolerance scale, okay? But there was no age by group format effect. It was just for the orthostatic intolerance scale, and nothing else was, there was no significant difference for any of the other scales. Okay. So what can we infer from this? The results really are suggesting that the response tree format is as useful and psychometrically sound as the original format, with the exception of the orthostatic intolerance scale, which took longer. However, our addition of the content to the instructions with each item may have confounded the true effect of the response tree format. The results provide beginning evidence that it may lead to fewer missing responses in older inpatients. And I just wanted to talk a little bit about that, and we don't really know why there was that slight age group trend of fewer missing responses in the older age group than in the younger age group. It might be that younger people got tired of the repetitive questions, they may have gotten bored, and so actually, you know, they may have stopped answering them or paying attention. So the results provide beginning evidence that researchers and clinicians can use the response tree format in individuals who experience difficulty understanding the original scales or who experience response burden without compromising the validity, the reliability, or the utility of the scales. Okay. And in terms of future research, because there's so little research done in this area, we really need more research to validate the study findings, you know, with perhaps different groups, and also examine the effects of the response tree format in populations with mild cognitive impairment. There's a lot written in the literature that people with mild cognitive impairment can participate in research, can respond to surveys with support, but there's very little research testing something like this in individuals who have mild cognitive impairment. So that's the end of my presentation, and open it up for any questions you might have.
So how would it work to use this in a study scenario? Would an institution come to you to get help refining their questioning, or how would or they use your technique in designing their question?
They might decide to. The whole reason why I wanted to do this is I want to do future research and intervention study on physical activity and looking at it if it prevents some of these symptoms. So in order to be able to include the population I'm interested in, I needed to test this first before going to a full study and including the scales. I guess it tends to be people who want to do research in this area with older adults who, you know, end up doing things like, okay, we have to go a step back, because most scales are tested in younger. They were designed for use in younger populations, right?
In the previous slides, it showed that there was a larger standard deviation among the older population for their response times to the questionnaires. What's your reasoning behind that?
Larger, well, it's fairly, to all the scales. I'm just looking at that slide right now. Really, we're looking at seconds, so it's, if their mean time was a little bit greater, when you look at the orthostatic intolerance scale, their mean time was double what it was for the younger people, but the standard deviation really isn't that much of a difference when we look at the total mean time. And here we're looking at a difference of really about 10, 15 seconds. Any other questions?
Do you think the type of scale makes a difference to how effective or not the response tree might be, the format might be?
I think it does, and I would, I mean, I didn't get into this in the presentation, but we really tried to preserve the content of the items and the responses, potential response options, as much as possible. So most of these scales had the option in the item and in the response option, they had the wording at all. Okay, so that may convey to people the researchers' interest in a varying degree of intensity of the symptom. I don't know if that would be any different in scales that don't already have that in the item and in the response option. So I think that's why we probably applying the response tree format to the scales, there wasn't really much, it didn't really change the utility, the psychometric properties that much. That might not, be true in other types of scales. So my advice would be to try to retain, don't go changing the whole content of the response options or the actual item stem.
Any other questions? Well, thank you very much.
My pleasure. Thank you for inviting me here today.
Thank you.
Mary,
Mm-hmm.
we actually have someone with a question
Oh.
online.
Didn't know we had people online asking questions.
Yes, they can actually ask questions. And one person said thank you, and she said it's a very interesting study.
Oh, thank you.
People asked, is this published yet? And who are the authors?
Okay. This is currently just recent, not even on the press yet. It's currently under review. It was just submitted. So and I was told I'll to expect a response in 3 months. So it may not be for a few more months that it gets published. The co-authors are Suraya Sidani, who is in the Department of Nursing, School of Nursing at Ryerson University. Dr. David Striner, who is, I believe he's retired now, but he's associated with the Faculty of Medicine in Psychiatry here, and also at McMaster. He's a psychologist and does a lot of work in, has written all of our undergraduate statistics kind of texts. And Dr. Catherine McGilton, who is a nurse, and she is a research scientist at Toronto Rehabilitation Institute, and also is an adjunct associate professor here at the School of Faculty of Nursing. And Cheryl Grady, Dr. Cheryl Grady was a collaborator on this project and a co-author on the article, and she is a psychologist over in the Rotman Research Institute at Baycrest, and is also affiliated here at U of T.
Thank you.
Okay.